Okay, I think we will go ahead and get started. So hello there and welcome. My name is Tyler Best and I am one of the Springboard community managers. Today's webinar, Continuity of Care, Preventing Family Planning Discontinuation, is presented by Springboard, an online community under the Breakthrough Action Project. Breakthrough Action is USAID's flagship program on social and behavior change. Breakthrough Action ignites collective action and encourages people to adopt healthier behaviors by forging, testing, and scaling up new and hybrid approaches to SBC. If this is your first Springboard webinar, then welcome. So what is Springboard? Springboard is an online community of over 4,000 SBC professionals from over 100 countries. Springboard can help you advance your SBC skills, connect with SBC colleagues and SBC leaders, and get inspired through resources, events, and jobs. If you're not a member of Springboard already, today's event with two presentations followed by time for questions and answers at the end. Feel free to use the chat feature on the bottom to introduce yourself and your organization. Additionally, you may also use this feature to ask any questions for the speaker throughout the event. We'll compile those and use them during the Q&A session. Now on to the show. Our first speaker is Billie Puyat Murga and comes to us from Johns Hopkins Center for Communication Programs, where she's a senior program officer for the USAID ReachHealth project in the Philippines. Over to you, Billie.
Thanks, Tyler. Good morning, good afternoon, and evening to everyone here, wherever you are. So as what Tyler said, I'm Billie Puyat Murga. I'm from Johns Hopkins Center for Communication Programs, working on USAID ReachHealth. It's a family planning project in the Philippines. And I'm here with you to share our ongoing human-centered design activity to reduce family planning, or FP, method discontinuation in the Philippines. Next slide, please. So this activity is a collaboration between Breakthrough Action, particularly ThinkPlace US, ThinkPlace Singapore, and ReachHealth, which is led by RTI and CCP as a partner. Next slide, please. So why are we doing this? Well, this is an important activity because contraceptive discontinuation is often overlooked. Even if discontinuation is a contributor to unmet need, most programs focus on bringing in new users or shifting current users to a more effective method. But that is not enough for couples to attain their desired family size. Next, please. Okay, so in this study, we are looking at two perspectives. For women, we want to gain an awareness of the Filipinas' FP journey and identify potential barriers and areas for intervention for the woman's family and community. For healthcare providers, we aim to understand how they can build partnerships with clients instead of just giving information, and to deepen their relationship with clients for continued support. Next slide, please. So we use the FBC flowchart as our guiding process. For those who are not familiar, there are three phases. One is define, design and test, and then apply. This is an iterative process with opportunities to refine strategies at each stage. Next slide, please. Okay, so we began our study last June 2021 by defining our intent statement, which I'll share later on. Then we conducted our discovery research in the field around, this is around, I would say, August last year, August and September. So after we generated insights and how might we statements, which helped us ideate and come up with solutions, we came up with 10 low fidelity prototypes, meaning these are just rough drafts, nothing final. We just finished actually sprint 1 testing this June, and now we're synthesizing the feedback. We'll prioritize the prototypes and develop an implementation toolkit, which we'll test in the next few months. Next slide, please. So the Philippines is an archipelago in Southeast Asia, and it's divided into three main island groups: Luzon, Visayas, and Mindanao. We made sure to visit sites in each island group and get a mix of urban areas and rural areas and Christian and Muslim areas. For the discovery research, only the local team was able to go because of COVID restrictions. However, for the testing sprint one, colleagues from ThinkPlace US and Singapore were able to join us in the field. Next slide, please. So now I'll share with you the results from the two phases so far. Next slide. So we consulted stakeholders and partners and came up with this intent statement. How might we understand the Filipino woman's contraceptive journey and improve the approach of healthcare providers to lower discontinuation? Next slide, please. So we conducted key informant interviews with 60 individuals across the three sites. They were discontinuers, partners of users, close family members or friends, healthcare providers, community leaders, and municipal representatives. Interestingly, we struggled with recruiting women who were married but did not have a child. We also realized how important recruiting is, and we made sure to give very specific criteria to our field partners. Next slide, please. So from these interviews, we generated insights. It's divided into two: users and healthcare providers. I can't really go into detail now because of the time constraint, but I can share our insights report later. So for users, there are 6 themes. First, the relationship with FP. This is about the woman's perception and knowledge about family planning. Second, motivations and drivers to use FP, which is usually centered around a better quality of life. Third, decision-making on using FP, which is heavily influenced by hearsay and common beliefs in the community. Fourth is trusted information sources about FP, and these are usually from family members because experience is very important. They also go to providers for commodities, but not necessarily for information. The fifth are journey touch points, and these are key points in the FP journey, which I'll go into more detail later. Last is we were able to define discontinuation as short-term or long-term, which is determined by the effect of the contraceptive on a woman's daily life. Next slide, please. So this is the contraceptive journey touch points that we observed. Looking at the green diamonds, you can see that the key decision point happens when they try out the method and then they experience a health issue. And then if they link that health issue to using a contraceptive. Next slide, please. As programmatic people, we've mapped out jobs to be done or potential points for intervention based on the user's emotional, social, physical, and economic needs. These are important to note because the decision to start, continue, or stop a method is rarely rational. So giving information is not enough. We need to address a woman's motivations and needs. Next slide, please. So the next set of insights is on healthcare providers. First, we must consider the HCP ecosystem and how it is set up to facilitate or hinder relationships with clients. Second, we should also look at how communities perceive HCPs. We found that they were not really the go-to resource for FP concerns until it was really bad and they needed medical attention. And third, there are challenges that the HCP faces given multiple health areas that they need to cover and activities that need high touch and high effort. Next slide, please. Now for the design and test phase. Next slide. Given those insights, we generated how might we statements. How might we statements are questions that reframe insights into opportunity areas. So for example, how might we generate trust and confidence in HCPs by tapping on existing community networks and grapevines? So these are just examples, and you can see how we reworded the insight, highlighting the core need. Then from these how might we statements, we ideated prototypes or solutions. Next slide, please. So we came up with a lot of solutions, but we were able to distill it down to 10 prototypes. These are clustered according to a woman's journey. So the green one is from awareness about a method. The pink one is when they're starting to try it out. And the blue part is them getting the support to continue using or switching. We used key informant interviews, intercept interviews, and observations for this testing sprint. Next slide, please. So we tested 10 low fidelity prototypes. Again, these are just very rough drafts and you'll see photos later. We did it with 66 individuals in the same 3 sites for continuity. And we added current users this time to see if it would help them continue using their method. Next slide, please. So I'll just discuss a few prototypes. So if you can look at the top left-hand side, this is a teleconsultation script that providers can use to follow up with clients. So the idea is to continue touching base with them and checking to see if they have any questions or difficulties with the method. Next in the middle is the anonymous box. As you can see, very, very crude. We just designed it ourselves. This gives people an opportunity to ask their questions anonymously. Then a healthcare provider can answer it and post it on a community Facebook group. The photo on the top right side is the busting common beliefs card. We kind of had difficulty with this. We printed cards with common beliefs and the corresponding fact. And then we also included a place for healthcare workers' number so that they could ask questions. But interestingly, some people didn't find the common belief to be a myth, and they actually found it to be truthful based on their experience. Below that photo is the Anytime, Anywhere checker, which helps women understand the possible changes that they're experiencing from using a hormonal contraceptive. And it allows providers to keep track of these experiences. Then the lower left-hand side is the conversational cards. So this gives couples or maybe friends an opportunity to talk about their FP journey and get that emotional support that they need. Next slide. So since we haven't finalized our testing feedback yet, I want to share some key takeaways from that the team had. So first, side effects are a huge concern to start using and continuing a method. Sometimes the woman doesn't even have to experience it. As long as she hears that it could possibly happen to her, she thinks of stopping. Yet the tendency is to downplay that experience and tell them it's normal or it will go away. And that's true, but it's also important for them to feel like they are heard. So clients need a way to verbalize what they're feeling, and that's what the checklist was for. And providers need the skills to empathize and figure out with the client how they can be supported on their journey. It is also important to follow up with those that have stopped using and see if they're willing to try another method. On the provider side, they need the support to offer clients their preferred method and not just what's available. This is kind of tricky because stockouts is a persistent issue. Providers also need the skills to acknowledge the beliefs that people have about contraceptives and address their concerns without invalidating their experience or the experience of people close to them. Next slide. So for our next steps, we will prioritize the prototypes based on the feedback, possibly combining a few. We will develop implementation kits with more detail and guidance to partners, and then test these with mid to high fidelity prototypes or something more concrete in the next month. Next slide. So that's it. Thank you so much for listening, and I will share insights report on Springboard. And once the testing report is ready, I'll share that as well. Thank you again.
Thank you, Billie, very much. So our second and third speakers are Dr. Holly Burke and Miss Eunice Wary, who will be co-presenting on pre-testing of the normal tool. So Dr. Burke and Miss Wary come to us from FHI 360, where Dr. Burke is a scientist and Miss Wary is a research associate. So over.
Hello.
To you both.
Thank you. Thank you so much. I am experiencing a little bit of delay, so if that happens, please just interrupt me and I can repeat anything. I really appreciate being invited to tell you today about our recent study to pretest a community health worker job aid for counseling clients on changes in menstrual bleeding associated with the use of contraception. I'm just going to pause for a second here and make sure, Tyler, could you let me know if you can hear me okay?
Yes, every once in a while there's a little delay, but I think generally you sound really good. Thank you.
Great, thank you. Would it help if I cut off my video?
Yeah, I think perhaps we could try that just to,
Okay,
yeah, that should help even.
great.
Thank you.
Thank you so much for your patience, and we'll move on to the next slide if that's okay. Thanks. Okay, so use of contraception often results in contraceptive-induced menstrual changes, or CMICs. Common CMICs include changes in bleeding, duration, volume, frequency, and/or regularity. Evidence indicates fears, misconceptions, or negative experiences related to CMICs among users often contribute to discontinuation and non-use of family planning. A review of family planning counseling materials showed that resources often do not address common concerns and questions about CMICs, and they also fail to highlight potential advantages of reduced or paused bleeding. In response, a facility-based version of the normal job aid was developed to address this gap. The tool uses a simple mnemonic device, normal, N for normal, O for opportunities, R for return, M for methods, A for absence of menses, and L for limit, to prompt healthcare providers to include 6 key counseling messages about CMICs to address typical concerns and questions that users often have. Next slide, please. After rollout of the facility-based tool, several countries expressed need for a lower literacy version of normal that would be appropriate for use in community-based programs. The community-based version of normal is intended for use as part of a comprehensive group education or counseling led by community health workers, and potentially as a takeaway resource for women to help reassure those who experience menstrual bleeding changes while using contraception. The goal of the study I'm going to talk about today was to pretest this community-based version of the job aid. Next slide, please. We conducted a 2-phase qualitative study. In the first phase, we pretested the community-based job aid, and in the second phase, we sought to assess the acceptability, utility, and recommendations for improving the job aid among community health workers, or community health volunteers, as they're called in Kenya. Next slide, please. The study was conducted in the South Rift Valley region of Kenya, in the Kurisuri North subcounty in Nakuru County, and the Mogotio subcounty in Baringo County. These settings were selected because they were within the Afya Uzazi program, and there was ongoing engagement with these communities. Afya Uzazi was conducted from 2016 to 2021, and it supported the Department of Health at the facility and community levels to strengthen their family planning services. Next slide, please. We chose to first study the job aid through in-depth interviews with CHVs, the community health volunteers, as well as current users and non-users of hormonal contraception and copper IUDs. During these interviews, we probed deeply into how people were interpreting and understanding the words and images on the job aid. We wanted to make sure we were using the correct words and images before testing the job aid in real counseling sessions with clients. Data from these interviews were rapidly analyzed and used to revise the job aid prior to testing in phase 2. Next slide, please. many changes were made based on the phase 1 interviews. The first image on this slide shows the first page of the original version we pre-tested, and the second image shows how it changed based on the phase 1 findings. The largest change was switching from pictorial representations to illustrations. We also changed the words menstrual cycle to monthly periods throughout the tool. Another change we made was to revise the image and wording for the opportunities part of the tool to enhance understanding of the opportunities to participate in daily activities that were easily recognizable in the study context. Next slide, please. Now I'd like to tell you about the methods we used in phase 2. 16 community health volunteers from the 2 sub-counties in Kenya were purposely selected because of their high family planning client loads the year before the study. The CHVs were trained on the 2-page job aid in April 2021 and given copies of the job aid to use with clients. 6 to 8 weeks after the training, the CHVs were interviewed about their experiences using the job aid and asked to provide feedback. The interviews were audio recorded, transcribed, and analyzed to identify qualitative themes. Next slide, please. The study engaged, at this point, I want to hand over to Eunice. Eunice, are you able to come off mute and take over? Eunice is a research associate at FHI 360 and was in the field because due to COVID, researchers from FHI 360 could not make it out there. And so Eunice and a host of a whole other researchers in our FHI 360 Kenya office led the stakeholder engagement and the research in Kenya. Eunice, please take it away from here. Thank you.
Thank you, Holly. One part of this study was stakeholder engagement, and during this time, the study engaged with the Department of Health in both Baringo and Nakuru counties and key family planning partners in both counties. And this was first to bring them on board in this study. And number 2 was to elicit buy-in, to also get support from them both in the field and at the county and sub-county level, and to contribute to the design and revision of the normal job aid. And this was done over a period of time, and it included sensitization meetings, introductory meetings, and also on study progress update. Next slide, please. Okay, now I want to talk about the key findings from phase 2 of this study. Can we go to next slide, please? Okay, during this time, on the left side, on each of the slide, you'll see the box with the quotes from some of our CHVs to support the findings that we got from the field. So prior to the use of job aid in phase 2, almost all the CHVs that participated in the study said that they did not have any knowledge on contraceptive-induced menstrual changes. And that was the first time they were coming across any explanation about contraceptive-induced menstrual changes. And typically what they would normally do when they come across this issue was to refer clients back to the health facilities to get information on this issue. So can we move to the next slide, please? Okay, the CHBs, when they came across the job aid from the training to the time they went to the field, they said that they liked the job aid, the way it was looking, because it helped them to understand the information that they were going to give to the clients in the field, and it answered so many questions that the clients had in there, that the clients had been asking them prior. to maybe getting family planning, or if of those who are having contraceptive induced menstrual changes. So some of them also said that, okay, all of them said that the job aid greatly helps them to provide better family planning, counseling to their clients. The CHBs indicated that they received new knowledge from training, and also while using the normal job aid, and that the normal job aid made their work easier by providing structure for counseling. Number two, it also provided visual aid, and this included materials that will show, that will accompany the messages that were provided in the job aid, and also assisted with explanations of each and every acronym that was in the job aid. The other thing is that it also showed the clients different types of family planning methods that they would normally not see in a health facility, but the health workers will always talk about. So it had pictorial evidence to show them that this is how the pill looks like, this is how an IUD looks like, this is how maybe this is okay. So it showed them different types of contraceptive methods that are normally used in Kenya. And it also provided explanations about different family planning methods and their corresponding contraceptive induced menstrual changes. Can we go to the next slide, please? Okay. So the job aid assisted the CHBs in Kenya to address myths and misperceptions that were common on the use of family planning. And some of the common myths and misperceptions that the CHBs came across in the field when they were talking to the clients included that one of the most common ones that they talked about was that while using an IUD might disappear into a woman's body once it's inserted. That's when women use family planning and they start bleeding a lot, or they experience contraceptive induced menstrual changes, that they are cursed, or they might have challenges in giving birth, or they might never give birth if they experience things like spotting. So this prevented so many women in these communities from accessing family planning because of the myths and the misperceptions that were there in the community. Can we go to the next slide, please? Okay, the clients, according to the CHBs, different clients used the information they got from the job aid and also from counseling to help them in various ways while using family planning. So the the clients who are not using family planning, it helped them and gave them an easy time to choose which family planning they would want to use. Number two, it also helped those who wanted to switch from the family planning method that they had to a different family planning method. It gave them an opportunity to make that choice because they could see the different contraceptive induced menstrual changes that were there in each and every, that would come with each and every family planning method. And this gave them a rough idea on what they would want to use. The other thing is those who had stopped using family planning methods because of contraceptive induced menstrual changes now came back to, decided to go back and start using family planning because now they were sure of what they were using and they had information on why they were getting the contraceptive induced menstrual changes. So some of the clients used this information to choose a family planning method that works for them. And for example, this, especially in Kuresoi North, this is a farming community, and most women are engaged in farm work, and they would choose injectables because this will help. One of the contraceptive inducements or changes for injectables is post-bleeding, and this will help them to continue having strength when they're doing the farm work. Okay, the other reason why that the CATVs gave that clients decided to choose a family planning method because clients decided to choose a family planning method before going to see a doctor, because now they have an understanding of what they were choosing. And also the clients would decide now if they have to go to the doctor when they have contraceptive induced menstrual changes or not, because they realize that this is something that is common and they will come and will stabilize after a period of time. Okay, some of the clients said that according to the CHBs, became ambassadors of family planning, and they were now spreading this information in the communities where they were, and they would talk to women and urge them to also take up family planning, while explaining to them that the contraceptive induced menstrual changes that they were undergoing are normal, and it's something that comes with different family planning methods. Can we go to the next slide, please? Okay, other clients said that the job aid was an eye-opener according to the CHBs. They said that the job aid had very useful information, and that this was the first time that they were receiving such kind of information on contraceptive induced menstrual changes. And that some of them also explained that the information helped them to reduce husband-wife conflicts, especially about menstrual bleeding changes, because some women explained that their husbands were complaining that they were bleeding a lot. Some of them were spotting, some of them were not having their menstrual bleeding at all. So their husbands were not understanding why this was happening. And because of the explanations that were provided in normal job aid, they were now able to understand why their wives were going through these menstrual changes. And for most of them, now they were encouraging their wives to even continue using the contraceptives. Can we go to the next slide, please? Most the normal job aid impacted the CHBs in different ways, and most of the CHBs reported that their status in the community was elevated because for the first time they were able to explain to women why they were having contraceptive induced menstrual changes. And this made them be respected in the community. They became people who are trustworthy because they would give information that the clients will also receive in the health facility. Also, they became well known ever since they started using the job aid in the community. So clients who had been canceled were even referring their friends and family to the CHBs, and even some of the CHBs who are not part of the study were either referring their friends to these CHBs who are part of the study, or were going to the CHBs to learn more about normal job aid, get copies of them, and also go and help people in their communities. And the other part of the impact of this study was that clients were now listening to the CHBs and would consult them anytime they had an issue with family planning or they wanted advice on family planning. And whenever they had contraceptive induced menstrual changes, they would first seek help from the CHBs before they would go to the health facility. Next slide, please. Okay, one of the impact of this study was the willingness of men to accept the use of family planning. And in this community, most men will seldom agree to allow their wives to use family planning. And most of them were even hostile to the issue of family planning and will not allow the CHBs to even sit with their wives to discuss about family planning. And when they read about the information that was in the job aid, that they either got from their wives or they heard from their friends in the community, the CHBs indicated that men started coming up to them to learn more about contraceptive inducements, changes, to learn more about family planning. And the men will ask for copies of the job aid to also go and read and to help the other men in the community to also learn more. And the men started changing their minds and allowing their wives to start using family planning after reading the job aid. And in fact, some of the men would go with their wives to the health facilities so that they can start using family planning. Can you go to the next slide, please? Okay, for most of the, for all the CHBs, they reported that the plans that they had canceled using the job aid have changed their minds and have started using family planning. And those who are discontinued before have returned to using family planning. And some of them, even though they had not started using family planning, had now started changing their attitudes toward family planning and were starting to accept that family planning is something that they could use. And this was mainly because from the normal job aid addressed misperceptions that were there in the community about family planning, and that the clients themselves started to understand that the contraceptive induced menstrual changes are things that are normal, and they come with different contraceptive induced menstrual changes come with different family planning methods. And also several men changed their minds about family planning and allowed their wives to start using family planning. Can we go to the next slide? So some of the CHVs also indicated that in the past, their clients were very much worried about contraceptive-induced menstrual changes because it was something that they were not understanding. They did not understand why somebody would go for an injection and then start bleeding or maybe stop bleeding. And the only way they could get an explanation about this was through other women in the community. So after going through the normal job aid and counseling from the CHVs who participated in the study, the clients started to embrace the changes and were now seeing it as normal. And for some women who had post-bleeding, they started seeing it as something of a benefit to them because they could now be free to go on a trip, to go to church, to go to markets, or even public places without worry that they might start bleeding abruptly, or that without worrying that maybe they'll soil themselves or things like that. And this actually helped women to understand that post-bleeding was not something which is a taboo, but it was something that came because they were sick, but it was something that was normal, and it was part of the contraceptive induced menstrual changes. And some of the women were also happy that because of post-bleeding, they can now save money that they normally used to spend on buying pads or sanitary. So women also realized that the contraceptive induced menstrual changes they experienced depended on the family planning that they were using. And for women who are having heavy or longer bleeding and were initially worried about that now understood that if they can switch to other methods of family planning that maybe that maybe did not have severe effects as the ones that they were using before. And some of them had even gone to the facilities and had changed the methods that they were using previously. Can we go to the next slide, please? Okay, I'll leave this part to Holly. Thank you so much.
Thank you so much, Eunice. I really appreciate you sharing all those insights that you learned during data collection. And so I'm just going to wrap up the presentation quickly so we have time for discussion, questions. In conclusion, we found the job aid was highly acceptable to the CHVs who participated in this small study. According to the CHVs, it increased counseling effectiveness, and it may increase uptake and continued use of family planning methods directly through counseling, or as we heard throughout the results that Eunice presented, indirectly through diffusion in the community. Next slide, please. Though future research is warranted, the job aid shows potential to improve counseling effectiveness as well as clients' uptake and continued use of family planning. We recommend policy makers and managers should consider introducing the normal job aid after pre-testing it with new audiences. And excitingly, since this study ended, the National Ministry of Health in Kenya has reviewed the study findings and the job aid, and they have adopted it for wider use in the country by including it as part of the their integrated family planning counseling tools for community health volunteers. Next slide, please. I believe Tyler already put it in the chat, but the normal job aids are freely available online in several languages at the link that's shown here or the one that was put in the chat. The tools, both the facility-based and the community-based versions, the version that we talked about today, they're available in Swahili, French, Spanish, and Portuguese, as well as English. We also have materials available for training the community health workers to use the community-based tool. So those are available as well to you if you'd like to use them. And next slide, please. There are many people, as I mentioned earlier, many people to thank for their contributions to this study. And we really appreciate you all for inviting us to speak at this event and are happy to answer any questions or hear your feedback and comments. Thanks.
Yes, thank you, Eunice and Holly. That was a wonderfully informative presentation. So let's move on to the question and answer portion or discussion if we get some interesting questions and discussion prompts going. So feel free to add any questions or thoughts that you have in the chat. I think that we've maybe just gotten one from Elvis. Let me go ahead and read that. So how can we be helped with this theme in camps for internally displaced persons? Thinking specifically in North Kivu in DRC. Do we think this tool from the FHI 360 team or potentially any of the insights or the prototypes from the Philippines team could be used within IDP situations?
I would say yes. I think it's worth a try. I do recommend pre-testing it with small groups of potential beneficiaries before making a bunch of copies. We do have it in French, but and the other languages I mentioned. So you could start with some pre-testing and see. But many, as Billie mentioned, this is a very common theme that this is side effects are the most common reason women discontinue using family planning. And when you dig into the side effects, one of the most common themes is menstrual changes that are induced by the use of contraception. So I do think it would resonate with women in that setting. But would recommend some pre-testing because as I mentioned, we found a lot of feedback through our pre-testing efforts in terms of changing words, images, and even when we did the first version of the Kiswahili version, we had a lot of like colloquial words that needed to be changed. That let's say in Nairobi, they would say things one way, but out in the 2 sub-counties we were working at, there was just a different way to mention that. So you'd want to really make sure you're getting the language correct. I hope that's helpful. But Eunice and Billie, please feel free to chime in here.
Okay, thanks, Holly. I believe that's, if I'm not wrong, that there's some parts in Eastern Congo where they speak Swahili, and maybe this normal tool can work if it's revised, and maybe the Swahili is tailored to that part of Congo. But I think this can be used there, and it can educate women just like it did in Kuresoi and Mogotium. Yeah.
I see we have another question from Laura. It looks like this question is for Holly and Eunice. How readily available were the modern contraceptive methods for those clients that you were working with using the normal tool, and for the CHWs or the CHVs in Kenya?
Let me check that. The contraceptives that were in the normal JOWED were readily available, except the hormonal contraceptive. The rest were readily available in government facilities, and clients could access them for free. Although towards the end of the study, I can see there was stock out of injectables, and this was because, especially that was in Nakuru County and in Presoi North, and that was because after learning about contraceptive-induced menstrual changes, women now, because as I said earlier, this is a farming community, most women went back to the health facility. Some of them were on long-term contraceptives, and they were having heavy bleeding. They decided to change to injectables, and at that point, we had Nakuru County had the stock out of injectables, but later on, it was after some time, the supplies were improved, and women started getting injectables. So I hope I've answered your question. But Holly, maybe you can add on to that.
Yeah, no, that sounds good to me. Are there any other questions or follow-up questions?
I'll let Laura write back in the
I think maybe
questions.
If I'm allowed, I can ask one.
Yes, go ahead.
Well, my question is directed to Eunice. And Eunice, I was just wondering whether you could be able to, maybe in another phase, to kind of translate these job aid messages to other languages, local languages, especially to the remote areas, and also to people living with disabilities, especially the black, with the vision impairment and also hearing impairment. Thank you.
Oh, thank you, Mudhoni. And for during the phase 1 and phase 2 of the study, the job aid was only available in Swahili and English. And that is because Swahili is widely spoken in Kenya. and many people also speak English. And when it was now, when we finished and it was adopted by the government, at that point now, I think what I can say it can evolve and it can be translated in other languages, but this can now be taken up by the by the Ministry of Health. And I think in conjunction with other partners, they can work together and do that. But job aid can be translated in any language. The normal job aid can be translated in any language. As long as there's a will, it can be translated.
And I did see another question, Eunice, maybe you could handle. There was a question about literacy levels in the study areas, and you know, that our colleague is noting there was, you know, some text written there, and so our colleague's curious if there was if the CHV read it out loud to the client, or how that was handled. Would you be able to speak a little bit to that, since you spent so much time out there?
Okay, I can answer that question. First, the CHVs in Kenya are people who are qualified. They have a secondary level of education, and they can speak both English and Swahili. For the community level, the reason why the tool was translated in Swahili is because people can understand Swahili, and those who could not read were read for the normal job aid by the CHBs themselves, and they were also given copies to go with home, so that they can they can share this information, or they can share the job aid with their husbands, or with the other sister-in-laws or sisters or brothers, those who can read and those who can understand English or Swahili, and those who can also read and write. But the literacy level, most of the clients, as the CHBs told us, were people who could comprehend. They could read and comprehend what was in the normal job aid. There were very few clients who are of childbearing age who could not read and understand Swahili at that time. Yeah, but when it came to now older people, they said that maybe as they were, because they shared the normal job aid widely, and some of them were shared in the women groups, and they would meet maybe older women who are not able to read and write, and they will help them to read and write, and then these women will now take this information to other women in the community. Yeah. I don't know whether I've tackled that well, or you still have more questions on that.
Are there any thoughts that you all have? We had one question about rural settings, especially where information is sparse. Any thoughts about using the tool in really rural areas, whether it be some of those prototypes in the Philippines or the normal tool from your testing in Kenya?
Okay, for the normal job aid, testing was actually done in the rural areas, the rural area of Kenya, especially Kuresoi was way rural. In Mogotio, there was a part of it which we can call peri-urban, but most of it was in the rural areas of Mogotio and also Kuresoi North. So this the pretest of this job aid was done there, and this is where the CHBs got the clients, and they canceled them with the job aid, and we believe that this can be adopted everywhere, either in town or in the rural communities, and it can work well. And that's why the Swahili that was initially in the normal job aid was revised, and it was simplified such that people in the community could understand what was being said and what was also written in the normal job aid.
For our prototypes, giving the phone number of the healthcare worker was a good they found it to be helpful for those in rural areas, especially those that community health workers don't visit often. So having the number of the healthcare worker to call or send a text was like it was more convenient for them to do that. And even for healthcare workers, we had a teleconsultation script for them to just call up and check in on them without having to be physically there. Thanks.
I saw a lot of interest in adopting the tool, which is so exciting. Please do let us know if there's anything we can help with. I did want to mention that the opportunities, the O letter of the normal mnemonic, it in the pre-testing, it had the most trouble with people understanding it. And I think that one has to be well tested in your context to make sure that women and community members can identify what you mean by an opportunity. So that part of the message is trying to highlight the advantages of pause bleeding. So we not only want to say that when you get contraceptive induced menstrual changes such as pause bleeding, it's safe, but it can offer you opportunities. And Eunice described the opportunities we identified in our study communities, which were, being able to go to the market, to church, to being able to do your farm work. But when you're pre-testing this in your community, please do spend some time on that to make sure the image and the wording around that part are tailored to your context. I hope that's helpful.
Thank you, Holly, for that insight. I want to be respectful of everyone's time, so I see we're at the hour. However, I would love to give all of our speakers just a chance for any final thoughts or any last words. Holly, should we start with you?
Appreciate everyone's interest, and please do feel free to reach out if the normal tool seems like it might be a fit in your programs. Thanks for having us.
Great. Eunice. Let's see while we wait for Eunice. Billie, any final thoughts or words from you?
I just want to say thank you to everyone, and I'm glad that I also learned about this normal tool, and I think it's something that we can look into as well. Thanks.
Great, great. And Eunice.
Okay, thank you so much for giving me this opportunity to present, and I'm happy to share with you normal job aid. And I'm happy to continue talking about it because it's something that I'm very passionate about. So thank you so much.
Great, thank you. And I think you all will have many follow-up emails from folks on here. It seems like people are very interested. So thank you again for taking the time and putting those presentations together. They were really invaluable and a great reason to come on Springboard and to join these webinars. So thank you for all of the presenters and for all of the attendees. And check out Springboard for additional opportunities like this. All right, thank you very much. Bye.